Doctor told black nurse to stay in her lane. She was the one who wrote the procedure he just botched. He said it in the hallway, not in a closed office, not in a private conversation between two people who had agreed to speak plainly. In the hallway of the fourth-floor surgical wing of Meridian General Hospital at 10:47 on a Wednesday morning, with two other nurses, a resident, and a patient transport aide within clear hearing distance, in the voice of a man who had decided that the audience made no difference, because the hierarchy made the audience irrelevant. Stay in your lane. 4 words, said with the flat finality of someone who considered the conversation already over, said in response to a woman who had just told him, calmly and with clinical precision, that the post-operative drainage protocol he had ordered for the patient in room 412 was inconsistent with the procedure that had been performed. She had said it quietly, in the register of a professional flagging a clinical concern to a colleague. She had said it with the specific vocabulary of someone who did not need to qualify their knowledge before deploying it, because the knowledge was the qualification. He had said, "I've been practicing surgery for 14 years. Stay in your lane. Her name is Celeste Oduya. She has been a registered nurse for 22 years. She holds a doctorate in clinical nursing practice. She is the clinical practice lead for surgical nursing at Meridian General, which means, among other things, that she is the person who writes the clinical protocols the surgical floor runs on, including the one the doctor had just departed from, including the one that the post-operative outcome for the patient in room 412 was now dependent on following correctly." She did not say any of that in the hallway. She said, "I understand. I'd like this documented in the patient's chart as a clinical concern." She said it in the same, even unhurried register in which she had said everything else. Then she turned and walked to the nursing station. What happened over the next 6 hours in room 412, and in the clinical records review that followed, and in the office of the hospital's chief medical officer, and in the meeting room where a protocol revision committee convened 4 weeks later would confirm what Celeste Oduya had known at 10:47 in the hallway, that she was right, that the deviation mattered, and that the patient deserved better than a system that required a nurse to fight in a hallway for the clinical truth she had written herself. Nobody in that hallway knew yet what she had written. Nobody knew that the document on file in the hospital's clinical protocols database, last revised 18 months prior, bearing the name of its primary author in the bottom right corner of every page, was hers. They did not yet know that the author and the woman being told to stay in her lane were the same person. They were about to find out. Subscribe and tell me where you are watching from. Now come back with me. Not to the fourth-floor hallway. Back further to where the knowledge was built, and to the 22 years that made it possible for a woman to hear, "Stay in your lane," and respond not with anger but with, "I'd like this documented." Celeste Oduya grew up in Baltimore, Maryland, in a household where the body was taken seriously. Not in the clinical sense, not yet. In the sense that her mother, a woman named Adaize, who had come from Nigeria with a secondary school certificate and the specific practical intelligence that certain people carry as a portable form of capital, had raised her children with a close attention to what bodies communicated. Adaize was not a medical professional. She was a woman who had been the primary health manager for a family of 5 across 2 decades of American life, navigating a healthcare system that she had not grown up in, learning its language from the outside with the systematic patience of someone who understands that the language of a system is the key to the system. She read every discharge instruction. She followed up on every referral. She asked questions until she understood not just what the doctor had said, but why. And when she did not understand, she asked again, not with apology, but with the simple confidence of a person who knows that their question is legitimate because their child's health is what is at stake. Celeste grew up watching this, watching a woman manage information the way a person manages any scarce resource carefully, completely, with attention to what was missing as much as what was present. She absorbed, from her mother, the understanding that the space between what a medical professional says and what a patient needs to know is not a given. It is a gap, and the gap is where the real work lives. She was 14 when she decided nursing was the work. Not because of a single moment, because of an accumulation, the way the nurse who admitted her brother during a hospital stay at 12 had been the person who actually explained what was happening, who had translated the physician's discharge summary into language her mother could use, who had been the continuous presence through the 3 days of the stay, while the attending physician appeared for 7 minutes on each of the 3 mornings and was otherwise a name on a chart. The nurse was the one who knew. Celeste had watched that and had understood, with the clarity that comes to certain people at 14 when the world offers them a clear image of what they are meant to do. That knowing was the work she wanted. She pursued it with the same systematic attention her mother had brought to following up on referrals. She went to a nursing program at a university in Maryland. She was a serious student in the specific way that distinguishes students who are studying a discipline from students who are building a practice. She was interested not just in the answers, but in the structure of the reasoning that produced them. Why did this intervention produce this outcome? What was the mechanism? What did the research actually show, and how strong was the evidence? And when the evidence was weak, what did that mean for clinical decision-making? She graduated and began working in a surgical unit at a community hospital in Baltimore. She chose surgical nursing. Deliberately, she had identified, in her clinical rotations, that the surgical environment was the one that demanded the fullest integration of what she knew, the place where the gap between what was documented and what was happening was narrowest, and where errors had the most immediate consequences. She wanted to work where the precision was highest. She wanted the environment that would make her better the fastest. She was good. She was better than good in the way that becomes visible over time, not through the dramatic moments that generate stories, but through the accumulation of correct decisions, each one made with more information and more reasoning than the one before. Her charge nurses noticed. The attending surgeons noticed. The ones who paid attention. She was asked, in her 4th year, to join a small working group reviewing the unit's post-operative care protocols for abdominal procedures. She was the most junior person in the room. She was also the person who identified the inconsistency in Section 3 of the existing protocol that the group had been living with for 11 years without recognizing as an inconsistency. She brought it to the group's attention in the specific way. She brought most things to most people's attention, not as a declaration, but as a question. Can someone help me understand the reasoning behind this sequence? Because I'm reading it against the current research, and I'm not finding the support for it. Nobody in the room could explain it. The working group revised the section. The revision was implemented. The working group's final report acknowledged the identification in 2 sentences in the methodology notes. She kept a copy of the report. Not because she needed the credit, she understood early that in certain environments the credit runs in specific directions and that fighting the direction costs more than the credit is worth. She kept it because the work was hers, and keeping a record of the work was a practice she had absorbed from her mother, who kept every discharge instruction in a manila folder in the kitchen drawer, and from a professional ethic she had been developing since she was 14, and watching a nurse explain what the doctor's notes meant. She went back to school while working. Night classes, then an online program, then a structured doctoral program. It took 8 years. 8 years of full-time nursing and part-time study of the specific exhaustion that belongs to people who are building 2 things simultaneously and have decided that the building is the point and the exhaustion is what the building costs. She earned her doctorate in clinical nursing practice. Her dissertation examined the relationship between protocol clarity and clinical outcome variance in surgical nursing, a narrow subject that was, in her understanding of it, not narrow at all. But the essential question, when the document is clear, do patients do better? The answer, across 712 cases in 4 institutions over 3 years, was yes. The effect size was clinically significant. The dissertation committee passed it without revision, which was unusual, and the external reviewer wrote in her evaluation that the methodology was more rigorous than most published research in the subspecialty. Celeste did not tell anyone at work when the doctorate was conferred. She was not secretive about it, she was not hiding anything, and it appeared on her personnel file from the day after conferral. She simply did not make an announcement, because the knowledge that the degree represented was already what she had been bringing to the unit every day, and the degree was only the formal acknowledgement of that, and the formal acknowledgement did not change the work. She moved to Meridian General 4 years after the doctorate. She was recruited specifically for the clinical practice lead role, a position that had been created, in part, because a healthcare administrator named Dr. Patricia Wu, who had been chief medical officer at Meridian General for 7 years, had read a white paper Celeste had published in a nursing research journal and had sent it to her department heads with a note that said, "This is the level of thinking our clinical protocols should reflect. Find out who wrote it." Celeste wrote the protocols. Not alone, she led a team, because the work was larger than one person, and she understood that work done by a team was more durable than work done alone, because the team carried the understanding forward when the individual moved on. But she was the primary author. She knew the evidence base for every choice. She knew where the research was strong and where it was weak, and what the weak spots meant for practice. She knew because she had spent 22 years building that knowledge, and she kept building it, because the field moved and the knowledge had to move with it. The post-operative drainage protocol for the procedure performed on the patient in room 412 had been written by Celeste Oduya 18 months prior. It was 12 pages long. It cited 47 sources. It had been reviewed by the surgical department's practice committee, including the attending surgical staff, and had been adopted by the committee on a unanimous vote. The doctor who told her to stay in her lane had voted to adopt it. He did not know she had written it. He had never asked who wrote the protocols. In 14 years of surgical practice at 2 institutions, it was possible, the clinical review committee would later note, that he had never asked who wrote any of the protocols. He was about to find out that someone had. The doctor's name was Andrew Marsh. He was 44 years old. He had trained at a well-regarded program in the Northeast. His surgical outcomes were, by the standard metrics, acceptable, not exceptional, not problematic, in the middle range of the department's attending surgeons by the measures the hospital tracked. He was well liked by the residents who rotated through his service, which said something true about him. He was patient with people who were learning, generous with his time in the operating room, willing to explain. What he was less generous with was challenge. Not clinical challenge. He could receive a question from a resident about a technical decision with the equanimity of a teacher. What arrived differently was the challenge that came from a direction he had not assigned authority to, from a nurse, from a support staff member, from anyone whose position in the institutional hierarchy he had drawn lower than his own. The challenge from those directions he received as category error. As someone speaking a language in a room where they had not been given permission to speak it, he had made this error before. Not in the dramatic form it had taken in the fourth-floor hallway, but in the smaller, quieter form of not listening, of receiving a clinical observation from a bedside nurse as a note to be filed rather than information to be processed. The bedside nurses on his service had learned, over the years, to route concerns through the charge nurse rather than directly to him, because the direct route had a specific yield and the indirect route had a better one. This was institutional knowledge of a particular kind, the knowledge of how to work around a person rather than with them, accumulated through the experience of trying to work with them and finding the cost too high. Celeste Oduya had not been on his service before. She worked at the level of policy rather than individual patient care, which meant their paths had not crossed in the 2 years she had been at Meridian General. She had seen his name on the protocol adoption votes. He had not looked at the name on the protocols. On the Wednesday morning in question, Celeste was doing a routine floor walk part of her role as clinical practice lead, a scheduled observation of how protocols were being executed in practice versus how they were written on paper, because the gap between those two things was the site of most clinical risk. She had been in room 412 for 5 minutes when she read the post-operative orders and identified the drainage protocol deviation. She had gone to find the attending, because the attending was the person with the authority to correct an order, and correcting the order was what needed to happen for the patient in room 412. She had found Dr. Marsh in the hallway. She had said what she said. He had said what he said. She had said, "I understand. I'd like this documented in the patient's chart as a clinical concern." This was not a retreat. This was a specific, deliberate deployment of the institutional mechanism that exists precisely for this purpose. The clinical concern notation, a formal entry in the patient record that creates a documented trail requiring physician review that triggers a charge nurse notification, and that, in Meridian General's protocol, also notifies the unit's clinical practice lead of the entry, which was Celeste. She documented the concern herself, at the nursing station, in the precise clinical language of her training and her doctorate and her 22 years, and she attached to the notation the page number of the protocol the order had deviated from, because the protocol citation was the argument, and the argument needed to be made completely. She sent a copy to Dr. Patricia Wu's office. Dr. Wu read it before noon. The clinical review was not punitive in its initial framing. Dr. Patricia Wu had been running hospital systems long enough to know that the way you frame a review determines its yield, and that a review framed as punishment produces defensiveness rather than information, and that defensiveness is the enemy of the systemic understanding that prevents the next incident. She framed it as a protocol adherence analysis for the fourth-floor surgical wing, covering a 90-day window. She asked Celeste to lead the analysis, because Celeste was the clinical practice lead, and because asking anyone else would have been the wrong signal to send about whose knowledge mattered in this building. The analysis took 3 weeks. It found 17 instances of protocol deviation across the 90-day window, involving 6 different attending physicians. 11 of the deviations were minor variations within the acceptable range that the protocol itself identified as clinical judgment calls. 4 were moderate. 2 were significant, meaning they had produced or had the potential to produce adverse patient outcomes. One of the 2 significant deviations was the drainage protocol in room 412. The other was from a different, attending on a different wing, a finding that Celeste included in the report without comment, because the report was the argument, and the argument did not require commentary to make its case. She presented the findings to the Clinical Practice Committee on a Thursday afternoon. Dr. Marsh was in the room. He was in the room because he was on the committee, which was a standing membership, which meant he had been in the room when the protocols were voted on and adopted. Celeste presented in the same register she used for everything, even precise, with the evidence in the order that the evidence required. She did not address the hallway conversation. She did not reference "stay in your lane" or the audience or any of the specific facts of what had happened. The clinical review was not about Wednesday morning in the hallway. The clinical review was about what happened to patients when protocols were not followed, and the evidence about that was clear, and the evidence was what she had come to present. When she reached the page of the report that addressed the drainage protocol deviation, she noted that the protocol in question had been last revised 18 months prior. She noted that it had been adopted by this committee unanimously. She noted the research basis for the specific drainage sequencing at issue. Then she said, "For the committee's reference, I want to note that this protocol was authored primarily by my office. I'm naming that not to assign credit, but because the committee should know that concerns about protocol adherence are concerns I take seriously in both directions, both when protocols are being followed and when they aren't, and including protocols that I wrote." She moved to the next slide. Dr. Marsh looked at the citation on the bottom right corner of the protocol page on the screen. He looked at it for a moment. He looked at Celeste. He looked back at the screen. He had 14 years of surgical practice. He had voted to adopt this protocol. He had read it, because he was the kind of surgeon who read the protocols, even if he had not asked who wrote them. He now understood something about the Wednesday morning hallway that had not been available to him when he was standing in it. He did not say anything during the presentation. He said something after, when the committee had moved into the discussion phase, and the specific deviation in room 412 was being addressed. He said, into the room, not directed at anyone in particular, but clearly intended for the record. "The protocol was correct. The deviation was mine. I should have followed it. It was 6 words more than he had given the hallway. 6 words that did what the 4 words had not done, which was, tell the truth about what the situation was. Dr. Patricia Wu, at the head of the table, noted his statement for the minutes. Celeste did not respond to it, not because she did not hear it, because the committee was moving to the next finding, and the next finding was what the committee needed to attend to, and the work was the work, and the meeting was the meeting, and the record was the record. And all three of those things were more important than the moment of being right. The committee adopted 6 protocol reinforcement measures from the analysis. The most significant was a new mechanism, a monthly protocol adherence review, cross-referencing patient orders against the standing protocols on a rolling basis, led by the clinical practice team. It was not a punitive mechanism, it was a systems mechanism. It was designed to catch the gap between what the document said and what was actually happening, before the gap became an adverse outcome. Celeste had designed the mechanism. She had included it as a recommendation in her analysis because it was the logical conclusion of the evidence, and because she understood that the point of finding a problem was not to have found it but to have prevented the next one. Dr. Marsh requested a meeting with Celeste 3 weeks after the committee presentation. She agreed. They met in her office, her space, her choice, not because she needed the advantage, but because her office was where her work was, and meeting there was simply the practical choice. He did not come with a prepared statement. He came with a specific question, which was the more honest form of the thing he needed. He said, "I've been on the protocol committee for 3 years. Why didn't I know who wrote these documents?" Celeste said, "What do you mean when you say you didn't know?" He looked at the question for a moment. Then he said, "I mean, I never asked." She said, "Yes." He said, "I've been thinking about why." She waited. He said, "I don't have a clean answer. I have some hypotheses that are uncomfortable." He paused. "I think I may have been operating with an assumption that I hadn't examined, about whose knowledge lives where in this building." Celeste said, "That's a more honest account than most people give." He said, "It's not generous enough to earn anything." She said, "No, but it's the beginning of something, if you decide to make it that." They spoke for 40 minutes. Not about the hallway, not about the words, not about the public nature of what had happened in front of 2 nurses and a resident and a transport aide. About the clinical work, about the protocol development process, how it ran, what the evidence basis looked like, what the challenges were in getting new research incorporated into bedside practice. About the resident he was currently supervising who had asked him, 2 weeks ago, a question about the drainage protocol for abdominal cases, and about how he had answered it differently than he would have answered it before the committee presentation, and what the difference was. Celeste listened to the difference. She said, "That's the right answer." He said, "I learned it late." She said, "Most people who learn it late. The question is what you do with it once you have it." He said, "I don't know yet." She said, "That's honest." He left her office. She returned to the protocol revision she had been working on before the meeting, a new section for the cardiac surgical wing, an area where the evidence base had shifted in the preceding year and where the current protocol needed updating. She made 3 notes in the margin, things the meeting had surfaced for her about the way attending surgeons processed protocol language that she wanted to incorporate into the revision structure, because the protocol was only useful if it was used, and it was only used if it was written in a way that fit inside the actual workflow of the people who were supposed to follow it. The work found a use in everything. That was the 22 years. The resident who had been in the hallway on Wednesday morning was a second-year surgical resident named Kwame. He was 29 years old. He had been standing close enough to hear both sides of the conversation and had processed it in the rapid, simultaneous way of residents who are always absorbing more information than they can immediately categorize, filing it in the specific way that experience gets filed not always as a conscious lesson, but as a felt knowledge that shapes the next decision before the decision is recognized as a decision. He had thought about it for 3 weeks before he knocked on Celeste's office door. He said, "I was in the hallway." She said, "I know." He said, "I didn't say anything." She said, "I know that too." He looked at her. He said, "I've been thinking about what I would do if that happened again, if I saw something like that again." She waited. He said, "I think I would say something." She said, "What would you say?" He thought about it. "I think I would say, I'd like to hear the clinical concern, and then wait for it to be addressed." She said, "That's a good thing to say." He said, "I should have said it then." She said, "Yes, but you're saying what you'd do next time, and that's the more important thing." He said, "Is it?" She said, The thing that happened in the hallway is over. What happens in the next hallway is still being decided. That's where your choice lives." He nodded. He was quiet for a moment. Then he said, "Can I ask you something else?" She said, "Yes." He said, "How do you write a clinical protocol? I've been reading them since I started the residency, but I've never understood how they get made." She looked at him for a moment. She said, "Do you have 40 minutes?" He said, "I can make 40 minutes." She turned to her desk. She pulled out the current revision draft, the cardiac surgical wing protocol, 3 sections in, notes in the margin from the meeting with Dr. Marsh. She set it on the desk between them. She said, "A protocol is an argument. It's an argument about what the evidence shows and what that means for the patient in front of you. Your job when you read one is not to follow it blindly. Your job is to understand the argument well enough to know when the clinical situation matches the argument and when it doesn't. And when it doesn't, your job is to say something. Through the right channels, in the right language, with the documentation that makes the concern legible to the system." She tapped the page. "This is how you make the argument. Let me show you." They spent 53 minutes on the draft. When Kwame left the office, he had 4 pages of notes. Not about protocols in the abstract, about this specific protocol, why this sentence said what it said, what research supported which recommendation, where the evidence was strong and where it was weaker, and what the weaker spots meant for how a clinician should read the language in practice. He would later tell his co-resident, on a Friday afternoon in the resident lounge, that the 53 minutes in Celeste Oduya's office was the most useful clinical education he had received in his residency to that point. His co-resident asked him what she had taught him. He said, "She taught me that a protocol is an argument, that you have to understand the argument, not just follow the conclusion, and that when the conclusion doesn't fit the situation, you say something and you document it, and the documentation is the argument too." His co-resident said, "Who taught her?" Kwame said, 22 years. 4 months after the committee presentation, Celeste Oduya was appointed to the hospital's Quality Improvement Executive Council, a position that had not previously included a nursing representative at the primary author level, and that Dr. Patricia Wu had restructured to include one, specifically because the protocol adherence analysis had demonstrated in concrete and reviewable terms what Patricia Wu had believed for 7 years, and had not yet been able to prove with the kind of evidence that changed institutional structures. Rather than individual opinions, the evidence was Celeste's. The structure changed. She attended her first executive council meeting on a Tuesday morning in a room that had previously held only physicians and administrators. She brought a notebook and a copy of the protocol revision she was working on, because she always brought the current work, because the current work was the reason for being in any room. She sat down. She opened the notebook. The room's agenda had 12 items. The third item was a proposal for a new patient outcome tracking methodology that Celeste had read about in a research journal the previous week, and that had significant implications for how the hospital measured surgical nursing. Quality. When the agenda reached item 3, the council chair, a physician named Dr. Samuel Reed, who had chaired the committee for 4 years and who had been skeptical of the restructuring that had added a nursing voice to his table, looked at Celeste and said, "Dr. Oduya, I understand you may have context on this item," she said. "I do." She opened her notebook to the page where she had written her analysis of the methodology paper. "I'd be glad to share it." She shared it. Completely. In the register, she always used even, precise, the evidence in the order the evidence required. She spoke for 7 minutes. The council was quiet in the way that rooms go quiet when the person speaking has more of what the room needs than the room expected. Dr. Reed said, when she finished, "That's useful. That's very useful." He made a note. Then he looked up and said, with the specific directness of a man who had been in enough rooms to know when an assumption had been shown to be wrong, "I want to say, for the record, that I had reservations about this appointment." "I don't have them now," Celeste said. "Thank you." She turned to the next page of her notebook. The meeting had 9 items remaining. She had prepared notes on all 9 of them. The knowledge is the lane. The lane is where you built it. Nobody gives you permission to be in it, and nobody's refusal removes you from it. You do the work. You document the argument. You show up to the room with the current draft in your hand, and the room adjusts. because rooms that do not adjust to the evidence eventually fail the patients who depend on them. The thing I keep returning to is Adaise's manila folder in a kitchen drawer. Every discharge instruction, every referral, the reading and the follow-up and the questions asked until the understanding was complete. A woman navigating a healthcare system from the outside, learning its language without anyone's help, managing the gap between what the professional said and what her family needed to know. She was not trained. She was not credentialed. She was the person who understood that the gap was real and that the gap was hers to close, and she closed it. And she raised a daughter who closed it professionally. At the level of the institution, for every patient on a surgical floor that Celeste Oduya was responsible for. Stay in your lane. 4 words that tried to make a lane where there was none, that tried to draw a boundary around knowledge that had no boundary, that tried to locate expertise in a credential rather than in the 22 years of work that the credential only partially represented. Here is the thing about lanes. You don't receive them. You build them. You build them out of 14 years of watching a nurse explain what the doctor's notes meant, and 8 years of working full-time while earning a doctorate, and 47 sources cited in a 12-page protocol, and the manila folder in the kitchen drawer, and the question asked until the answer is complete. Nobody gives you the lane. You build it until it is undeniable. And when someone tells you to stay in it, what they mean is, stay in the small version of it I have assigned you. What you do with that instruction is you go back to work and you make the lane larger. Here is the question I want you to sit with, the honest version. Is there a room that has decided your lane is smaller than it is? Not a room that has challenged you. Challenge is useful. A room that has drawn a line and told you the line is the limit. That has handed you a lane and said, this is your size. And are you building? Not protesting. Not petitioning the room to redraw the line. Building the way Celeste built, the way Adais built, the way every person in these stories has built by doing the work completely, documenting the argument, showing up with the current draft in your hand. 1 word in the comments. Not the person who drew the line, the thing you are building. 1 word for the lane you are expanding. If someone you know was told to stay in a lane this week, a lane that was smaller than what they have already built, share this with them today. So they know that the work is the argument, and the argument is in the record, and the record is theirs, and nobody who voted to adopt their protocol gets to tell them where the lane ends. Subscribe. Because I am not done finding the people who wrote the thing the room was following without knowing it was theirs, and every time I find one, it reminds me that the knowledge was always there, in someone's hands, waiting for the room to have the courage to look at whose hands they were. And next time, I want to tell you about a 66-year-old Haitian-American software architect who spent 17 years submitting the same data security framework to a federal agency that kept contracting around. And on the morning, a major breach exposed exactly the vulnerability his framework had addressed. The agency called him, not to apologize, to say, we should have listened. And he said, I know. And he went in, and he fixed it. Same story. Different architecture. Same patient. Rigorous mind that never stopped building. I will see you there.